Good afternoon, everyone. Prynhawn Da. Your eyes are not deceiving you. Katie has not shapeshifted into me. Our director is pretty much superhuman, but I'm not aware of that superpower yet. So it's down to me to introduce this next session, which focuses on a piece of research carried out by one of my esteemed colleagues. So we've already heard today over some fantastic sessions about some of the challenges facing the sector. Obviously, the same is true of sectors more widely, like health. We've also heard about the importance of the involvement of other services in Housing First and people who specialise in certain things. So we heard about that from Moya and Nikki at Basis. We also heard Alex Smith talk about the complexity of people in Housing First and the real complexity of some of these support needs. And again, the need for a range of specialist and wider services to be involved to address those needs. So, of course, health and in particular substance use and mental health services are a vital part of this. More important now than ever, given the push here in Wales to rapid rehousing and this maintenance of fidelity in Housing First against this kind of very challenging context. So, of course, the accreditation process that we've heard about does look into this as part of Principle 10, looks into this wider picture and the involvement of other services in Housing First projects. But my colleague, Gareth Lynn Montes, has carried out an excellent piece of research into the involvement of mental health and substance use services with Housing First projects across Wales. So I will turn over to him if he's ready. Take it away, Gareth. Thank you very much.
Thank you very much for the introduction, Alex. And yeah, well, the first thing I'll say is that this has been the research project that has taken most of my time for the last year or so. And that although it's not yet published, this is going to be showing some of the preliminary findings, and we'll be very happy to publish it in the next month or so. So I'll go into some of the findings later on. But first of all, I guess it's important to give a bit of an introduction of why we're even doing this in the first place. And I don't have to explain Housing First to all of you. You all know what it is and what it isn't. And but what I will say is that through the Housing First Wales principles that Cymorth Cymru has helped to develop for Welsh Government and alongside Welsh Government, we have there is an acknowledgement that in housing, in the principle number 10, that the widest range of services are involved from the outset. So these include health, substance use, mental health, the police. So it's important that individuals can access them if needed or wanted. And I guess that's a key thing with everything Housing First, if needed or wanted. As well, there's been a much more of a recognition over the last 5 years or so that homelessness is not just a housing issue. You don't just put someone in a house and that's it. End of it. It's a cross-government and public service issue, including all of these different services as well. And in that, following that ethos, there's been a bit more of a joined-up work between Welsh Government policy and strategy, looking into homelessness and how that works with mental health and substance use services. As well, complex needs funding from the health budget has been made available to support projects working with people experiencing homelessness, using that recognition that all of them have to be working together. However, people were still reporting challenges, and this is something that came apparent in the accreditation process, hence the purpose of this research. So what does this research want to find? And I'll put forward the 4 research aims that we established at the beginning of the research, and I'll go back to them at the end of the presentation to see what the research has found. And I invite you all here in attendance to have a think about these research aims and to, as I'm talking, see if it's as I'm speaking and presenting what the research has found so far, think about if it's something that you've experienced or that you think is happening in the services you work with or work for. So the first research aim, I think, is pretty straightforward, which was to evaluate the involvement of mental health and substance use services in the planning and delivery of Housing First projects in Wales. Secondly, to examine whether this is based on actions of individuals or whether there is evidence of strategic commitment and systematic involvement. Number 3, to highlight examples of existing good practice within Wales and beyond. And hopefully in your services, you can think of many good examples of good practice. And lastly, to offer recommendations to new and current projects about improving the involvement of mental health and substance use services in Housing First projects in Wales. Because I want to make this pretty clear, the whole purpose of this research is not to just say, this housing first service is terrible, or mental health, substance use, or they are terrible here. No, there's no use in that. And I think we want to be really proactive with this research to show that there are solutions, there are ways forward, and that there's things that can be improved, and provide practical examples and evidence of how this can be done. So I know some people may read or may listen to this presentation and say, oh, just bashing at what we do, but that is most certainly not the case of what we want to do. I know everyone's going to leave the presentation when I start talking about methodology, but I think it's very important to establish a bit about the methodology and what was involved in the research to understand some of the things that the research found. And it was quite complex in a way because of just how different lots of the projects involved are. So first of all, I'll say what projects were involved in the research. We spoke to the Conwy Denbighshire Housing First project in North Wales, which is led by the local authorities. We spoke to the Cardiff Housing First project, which is led by the Salvation Army. We spoke to the Merthyr Housing First, which is also led by Salvation Army. Both the Swansea and the Anglesey Housing First projects by the Woolwich, the Carmarthenshire one, which is a joint partnership between Hafan Cymru and NACRO. We spoke to the Gwynedd Housing First project, led by Shelter Cymru, which at the time was quite a new project, and lastly to the Newport Housing First project, which is led by Pobl, but has since expanded to other parts of the Gwent region. So just as you can see, that just by the lead organisations, these were quite different, and thus the makeup of the projects were different as such. The funding streams, most of them came from Welsh Government, but some of them were from external sources of funding, and the length, as we've seen earlier today when we were speaking about the Anglesey or the Ynys Môn Housing First project. And I'd like to extend my congratulations to Joe and the rest of the team there for the accreditation. But they were first started at a time where we didn't even have the principles, and whereas on the other hand, the Gwynedd one was just a few months old at the time. It wasn't just useful to talk to people involved in the Housing First projects themselves, the staff at these organisations, but it was important to speak to a wide range of different stakeholders involved in every aspect of Housing First that we are considering for the research. So apart from the project leads and the support workers in these organisations, we spoke to commissioners, we spoke to mental health and substance use practitioners, and more importantly, obviously, we spoke to the tenants that for whom Housing First is supposed to be, for whom Housing First is here for. In total, in the research, I spoke to 55 different people across 52 different interviews, who gave me a lot of different opinions and a lot of information on what to include in the report. There were challenges, and I think it's very important to highlight them just for what is going to come in the presentation, which is, whereas in most cases, for most of the stakeholder groups, I was able to speak to at least one representative in all of the different Housing First projects. This was not always the case for mental health, and this was down to several reasons. Sometimes the Housing First project said that they didn't know who to turn to, or they couldn't give me a lead contact, and in other cases, it was just down to not being able to arrange an interview or not getting a response after sending several emails. And we also, and although I'm not going to talk about this much in this presentation, we did additional interviews with Housing First projects in Finland, Greater Manchester, and other parts of Wales to have a bit of a comparison, to be able to, especially when it came to the recommendations, to say, oh, what's working elsewhere, what can we recommend in Wales, but also to see if these problems exist elsewhere. And apart from that, well, I've been doing research into Housing First for the last 3 years or so, so it was always good to have that point of comparison. So the next few slides, I'm going to talk about the different themes that came up in the interviews, and each theme in the report is going to be its own section, and in here it's going to be its own slide. So the first one, in a way, is similar to the method. It could have fit into the methodology, but I think it was important to highlight it just as a theme in itself, and that is the differences at the strategic and operational level of the makeup of the projects. So, for example, some local projects that we interviewed took advantage of the fact that there was other things in place that helped to deliver these services. For example, the Ynys Môn and the Gwynedd project took advantage that in the local health board there was a harm reduction team which operated in a very psychologically informed way, and almost as a bridge in the gap between substance use and mental health. Likewise, down in Swansea, there is a dedicated healthcare homeless team, which provided very quick access for healthcare needs to those working in the project, but also the more wider homeless population in Swansea. A few other projects, Cardiff and Merthyr and Rhondda, have multidisciplinary teams which are working and should help to bridge the gap between all the different services involved. At the same time, there are differences within the teams themselves. Some teams have a mental health or substance use worker integrated into the team. And I think it's very important to highlight these, because sometimes the difference between being able to access mental health service, substance use service, is down to having these other things in place or having a dedicated worker. And that shows some of the examples of best practice that the research found and is highlighting is down to these things. And who knows that if some of the projects which maybe didn't have so many examples of best practice, what they could achieve if these things were in place as well there. So the next theme that came across a lot was how involved mental health and substance misuse services are at the very beginning and their strategic buy-in and engagement. And there was a quote from a commissioner, which was, "Housing first is something that everyone has to be involved in to make it work." And I think that throughout the themes that we've been talking about today, that is very clear. And there was the evidence found, and this was mainly speaking to commissioners and project leads, is that there was health, and this is not just mental health and substance use services, there was quite a lot of input from at the commissioning stage, and where there wasn't much of a say in designing the project, but also a lack of financial stake. And as another commissioner said, unless a project has partners who are investing money, it will only get lip service, not corporate buy-in. So there was almost a belief that to health to be more involved, it has to be more involved in the commissioning stage, and then in the long run, we'll see a much more integrated service. However, on the other hand, another commissioner said that you have to work towards deadlines rather than designing the best service available. So sometimes, just because you want to have a housing first project in the first place, you're not involving health in a way that maybe perhaps you should. But these are things to consider just at a commissioning process. As well, when it came to strategic leadership, sometimes we found that it wasn't, not everyone was involved in steering groups or similar structures. So sometimes there wasn't representatives from mental health, sometimes there wasn't representatives from other services, which the research weren't looking at, but still important to that they should be involved. And the fact that these steering groups or these meetings were not often strategic. They were mostly about operational issues. So they were not talking about long-term strategy on how to deliver housing first or how to expand housing first, but it was dealing with operational issues. And there's plenty of reasons why this would be the case. Not necessarily, it's good that these are spoken about as well, but sometimes it needs to be a bit more of a leadership, or that's what at least came through the interviews. The next slide, the next theme that we're going to talk about is very much not unique to Housing First services, and all of you, I guess most of you here will have experience of this, and it's about accessing mainstream mental health and substance misuse services. There was a complaint from everyone, all the stakeholders involved, basically, that it's a very slow, drawn out process, and that it means that you know what it means. It means that it takes forever to get any kind of service, and this is very much not just a housing issue. I know that if I or any of you here try to access any kind of mental health services, it's something that's going to take a long time. And there was a recognition from all the stakeholders involved again that a lot of it was down to a lack of funding, a lack of staffing, and just a pressure on services. However, there was also this doesn't mean that it created frustrations for those involved in Housing First. And there was very much a belief that there was a lack of crisis response at times. And there were some very vivid experiences explained to me in the interviews where you'd think that there'd be a crisis intervention, but then you get an appointment for 2-3 months' time. And you may ask yourself, well, how many crises can happen in that same time? And as a result, you end up having a lot of mental health support provided by support workers who have not been trained to do this. And there is a worry about support workers who told me in these interviews that, I'm trying to soften the blow, but I'm not sure if I'm giving the right advice, or maybe what I'm saying is unhelpful. So it's important that there is this access to these mainstream mental health and substance misuse services to deal with crises and just anyway. Also, what does waiting times do? Well, for those in receipt of services, the Housing First tenants, it really acts as a barrier. And people do understandably get frustrated about waiting several months to be seen, but also the lack of communication between. And sometimes you feel that you're being let go and not being supported. And that's understandable. There are explanations for it. As I've said, that there is a lack of staffing, a lack of funding, but that doesn't mean that the other thing isn't frustrating or a problem. And what another thing that came across a lot from those involved in housing, in delivering Housing First, and those tenants of Housing First, is just how inflexible some services were, and how through missed appointments, cases of antisocial behaviour, you'd be put off your services, and you'd have to start the whole process again, which, as we all know, as I'm going back, it's a very slow and drawn out process, which ends up again creating this frustration about how difficult it is to access the services. And there was a complaint that they were quite largely inflexible. I'll move on to the next theme, which is about assessment, referrals, and appointments. And although they are three very different things, they do come from I think the issues around them stem from the same problem, and it's a bit of a lack of coordination between the services involved, and which resulted in a lack of understanding of each other's services. I was told in these interviews by professionals working in substance use services and in mental health services that they didn't know how any of the assessments or referrals worked, and they worked daily with people who they thought should be considered for Housing First, and they didn't know if they could refer them directly. Whereas in other cases, it was a bit of a bureaucratic process where you had to refer them first to local authorities, and then the local authorities would have to choose. And that I was told by these professionals in substance use and mental health, saying, well, we are the ones who've been working with them for this long. We should have a bit of a say. So I think there is room for a bit more flexibility as well from Housing First services and the commissioning of these services as well, based on the evidence from the interviews, to involve these other services a bit more in the process. And I know this is probably different from each local authority and from each project to the rest, but it's something that they've come across. As well, some of the problem with not having these joint assessments or joint referrals or joint appointments is people having to tell their stories over and over and over again, which, as we know, it's not something that it's nice to do, having to recount all these experiences or trauma. And it's something that, as a Welsh Government mandate, we're trying to move away from with a no wrong door approach and the such. And so sometimes it's a bit more of that coordination would lead to people who should be at the centre of Housing First not having to repeat these traumatic stories over and over. However, there were examples of good evidence of joint appointments where coordination on the ground level is really positive, and you have these joint appointments between substance use workers and Housing First staff going into someone's home at the same time and doing it, or working together in the same place and getting people to come, but also coordinating visits. It's probably not the best thing to have 3 or 4 different people coming to your house on one day alone or 2 days of the week and asking all the questions and doing all the assessments and all that. Rather, it's probably best to move it across the week. Or for some people that does work, but it's a case of consulting with them and working in a bit more coordination. Again, there's an understanding that there's at times a lack of staff, which means that this isn't always possible. The next theme that came across in the interviews was those of attitudes and the compassion and stigma. And this, again, I don't think is unique to Housing First service. I think it's very much a wider issue with housing and homelessness. And a lot of the interviewees with lived experience spoke about how they felt that they were discriminated for past interactions with services or for being homeless, full stop. And lots of people said that it's very hard once you get a reputation, to get rid of that reputation. And this was especially the case in some smaller communities where maybe there are fewer professionals, so there are fewer people who you're going to be interacting with. I will say that most of these stories that or examples I was given during the interviews were not necessarily through interaction with those mental health or substance use services, but rather with other services which sometimes work in coordination with them. And these were mainly GPs, pharmacies, and the police. Especially GPs are probably one of the examples, because some GPs are often the primary point of access to mental health, especially, but also substance use services at times, and sometimes these can be problematic in accessing for people with lived experience. And yeah, there was plenty of examples, quite negative examples of these interactions, and they'll be in the report. Some of them there's no point to repeating here with such a large audience because of how graphic of they were. And and again, going back, there's something that has been encouraged by Welsh Government, and something that I know Cymorth has taken quite a leading role in, is to make the sector psychologically informed and using trauma-informed approach to what we do. And there was a frustration at times from people involved in Housing First projects, and also the people, the tenants in Housing First projects, that whilst the projects themselves were working in quite a psychologically informed way, that was not always the case for the services that you were interacting with. And even with these services, it depended on the professional. There was I think there was an example of a support said, or that they worked with about 16 GPs, and it was almost a bit of a Russian roulette, depending on who you got, of how much of a trauma-informed approach they have. And again, a lot of it is down to lack of training, which is down to a lack of staff availability and a lack of funding. So there are very much reasons for it, but it's something that I think it's still important to highlight, because it's something that came across a lot in the interviews. The next theme that came, and it has a bit of a connection with some of the themes that I've already spoken about, is about the barriers facing people with co-occurring mental health and substance use issues, what we'd often call dual diagnosis, but I know it's something that we've moved away from, or we try to move away from that term. And there was very much a case, a feeling among especially the people at the centre of Housing First, the tenants, that it was a bit of a pass in the buck, that it was the case that very much had co-occurring mental health and substance use issues, but they tried to access any kind of service and they say, oh, you have to sort the other one first out. And it worked both ways. There were examples of people who very much use substances to overcome, or in their views, to try and overcome their mental health issues, and they try and access mental health care, and they say, actually, no, they have to sort out their substance use issue first, and then we can work on their mental health, and vice versa. And again, I don't think this is unique to Housing First. I don't think some of these findings are not going to be surprising to many of you in the room, but they are persistent, and it's still even so important to highlight, especially given that it's something that Welsh Government have also considered about how this should not be the case. People should not be discriminated against because of co-occurrence of mental health and substance use issues. But again, I think it goes down to a problem of staffing and availability, which at the end of the day is the response to many of these issues. And it's not a cop-out, but it is what it is. And there was a lot of evidence of this being the case. The report has a lot of examples of people being turned away from services. I'm not going to repeat them because I don't think it's nice to repeat these stories on a call with all these people, with all of you here, but they will be in the report. Sometimes, however, there was the right call, and I think there was sometimes examples put forward to mental health and substance use practitioners, but also to Housing First staff, that sometimes one had to be prioritised over the other. So it's about treading the line between when it's the right call and when it's not the right call. One of the other things I'm going to talk about is cultures and joint working, and this is how Housing First staff or Housing First projects relate to health services, including mental health and substance use. And there was a quote from a support worker, which is, I always feel like it's us and them, referring to their relationship with these health services and professionals. And another support worker said that them and the health spoke different languages. And this is, I think, they highlight some of the barriers that the research found, and it is worth mentioning that there was a feeling that there had been improvements, that over the last 10 years there had been a gradual improvement between the relationship between the two, and that the health professionals increasingly took the opinions of support workers into consideration. Part of the reason, I think, of what I came apparent from the interviews was that sometimes it's lack of communication concerning strategic long-term aims, and sometimes that is not down to individuals on the field, but it should be at a higher strategic level where these are communicated, and why there was maybe about these challenges. However, there was also still some stigma towards support workers from professionals saying, "Oh, they're just support workers. What would they know?" And again, these are probably very minor examples, but they're the ones that always stick out, and they're ones that we should look to end and eradicate to be able to have this joint working that actually works. However, as with everything, there were several examples of good practice and some very practical ones. I think there was an example in the, if I remember right, the Newport project, that you had the Housing First team and you had the substance use team which they work with, that had a joint WhatsApp group. And it served several purposes, that WhatsApp group. It served the purpose of being able to talk about emerging issues, saying, "Oh, I visited so-and-so the other day, and for whoever visits them next, please keep an eye on this other thing, or have you considered talking about this, because they were moaning about this a few weeks ago, so it's probably worth checking up again." But it was also a way to create informal relationships, to be able to talk and chat about stuff, people sharing jokes, memes, light-hearted banter, whatever you want to call it, and it created a sense of team, and it meant that you knew people. And this is really important, because it is when you are going to support someone, you can say, and this was an example given to me by a substance use worker in Merthyr, said, "Oh, I can go to talk with someone who I'm supporting. I can say, hey, I don't know much about housing," when they are presented with housing issues, and say, "But I can give a ring to so-and-so," and you name that person, a friend of mine who works in such and such organization, and we can try to sort it out. So I know they'll sort it out. So it's very important to have this joint working for the delivery of services. Again, and I think this feeds in very well into the next one, which is that these individual relationships are very important, but we shouldn't over rely on them, because as the aims of the research spoke about, we were investigating if the integration of these services was down to individuals, or if there was a systematic and culture ingrained into it. And it's important that not one individual should have all the knowledge, or should have all the relationships, because as we know, there's a lot of staff turnover. We know that in the sector, everyone moves from one place to the next, and it means that a lot of knowledge can be lost just by one person leaving, and a whole relationship that has been built over years can be lost. There was an example of some people relying on old contacts, so people that maybe worked in that job and had moved other jobs, that they still got contacted, whereas the person who'd been newly appointed for that role wasn't contacting, created a bit of a vacuum in communication there, just because someone had been proven to be quite reliable. And I will say there was many examples of individuals going the extra mile and making things happen, making these relationships and integration between services going. And I know there was an example about a nurse working in this dedicated homeless team in Swansea, that every single person I talked to said, "Oh, if it wasn't for this person, we wouldn't get anything done. This person is fantastic, is a saint. Everyone loves her because of how much she does." And so it's important that these things happen, and the people have to be commended. And I want to take this time to thank really everyone who partook in the research and helped me, and who helps to make Housing First work, and those who I didn't speak to, who I know also go the extra mile and do a lot of work, and they have to be congratulated. But also we have to consider about how this has to be systematically ingrained into the projects, because people will leave, people will retire. So this is important to consider. And hopefully getting to the end, but I'll talk about how the COVID-19 pandemic has affected, which is impossible not to consider it in how Housing First has been led in these few years. And most of the projects considered were established at the end of 2019 or the beginning of 2020. And obviously it takes time to recruit the right people. It takes time to get the people that you're going to house. And before you know it's March 2020 and the COVID-19 pandemic's happened, and it's completely changed everything. And this has had effects on service delivery, especially if we are thinking about health, which had a lot of priorities back when with the pandemic and had prioritized. And so sometimes some of those services weren't available. And we had the question of strategic thinking and the priorities from a more of a higher up level. Maybe housing first didn't become a priority when you had to think of a health pandemic and vaccinating the whole population. We had examples of the pandemic allowing or having to work online, and how easy it is to just give a phone call or to set up a Zoom call, that of better examples of joint job working, how that improved. But at the same time, we had examples of more siloed working, because maybe those personal relationships you had of going to a hospital and seeing people, or going to a service and seeing people, were lost. We did have some successes, and we saw how, and this again not unique to Housing First, but the fast tracking of Bubidol was a major success, and we have to focus on these successes. We have to think about why they were successes, how we got rid of some of the bureaucracy in the place. So apologies for that, I have no idea what that was, so sorry for that. And we saw that how fast tracking was a success. And going very quickly to the conclusions, when we look at how, going back to the aims that I was talking about at the beginning, some of them have answered themselves, but when we look at, if we evaluate the involvement of mental health and substance use services in the planning and delivery of Housing First projects in Wales, we see that probably more could have been done, or more is left to be done. And sometimes just getting the Housing First projects off the ground was a priority. We move to the second one, which is to examine whether this is based on the actions of individuals or whether there is evidence of strategic commitment and systematic involvement. We see that as it is, there is a lot down to individuals making this happen. But it is also worth mentioning that a lot of these projects are quite recent. You've only got 2 or 3 years that they've been in existence. So maybe there isn't been the turnover of staff to really assess if it is systematic or if it's just down to individuals. Highlighted examples of existing good practice. Well, I've mentioned some of them in the presentation so far, but it's also some more of them will be more actively mentioned in the report, and you'll be able to read that when it comes out. And lastly, to offer recommendations. Well, some of them, although I've not mentioned any directly, you can get an idea from some of what I've mentioned what the report is going to recommend. But I guess you'll have to wait for the report to be published and to read the recommendations fully. I mean, give you a bit of homework for when that comes out, and also because some of these are still under consideration, working collaboratively with Welsh Government and health professionals, so we really get a broad understanding of what we should be recommending. So that is the end of my presentation. Very much apologies for the fireworks that were there at the end. I have no idea what they were.
Thank you very much, Gareth. And yeah, I must commend you for barely batting an eyelid during what sounded genuinely like gunfire outside. So very well done. And thank you for a great summary of what I know was a very intensive, thorough piece of research that's taken a lot of your time and effort. Presenting a somewhat sobering picture, I think it's fair to say, but one with a lot of lessons and opportunities for Housing First and partners going forward. And like everybody else, I look forward to reading the full report in a few weeks. I will keep an eye on the Q&A. We have about 10 minutes just under for questions. We do have some that we've already been sent, so I will stick with those for now. Gareth, people might be wondering why we specifically focused on mental health and substance use.
Well, I guess that's something that came quite clearly from some of the interviews done before in the accreditation process, but also some of the information we know from projects elsewhere. We know that many of the people presenting to Housing First or homelessness services more broadly present with a wide range of mental health and substance use issues. But also it's a question of scope. I know we could have spoken about a lot of other stuff, and I know we considered it at different points in the project, but you have to put a scope. And well, we can always have a part 2 talking about criminal justice, which I think it's something that could also be very interesting and useful.
Yeah, I mean, as you say, there's always that issue of scope with research. We absolutely acknowledge that people with long-term experience of homelessness tend to have various physical health issues, but it's the mental health and substance use issues that come up a lot, especially in things like the accreditation. So that makes sense. Thank you. You've touched on this a bit, but perhaps I could ask why do you think it's so important that a range of services, including health specifically, are involved in Housing First?
Well, again, it's down to some of the evidence we found from abroad. Some of the most successful projects abroad have involved health services from the very start, and you are going to people in Housing First are going to be accessing these services, and they are going to be relying a lot on these services. So why shouldn't they be involved? Why shouldn't they? It's important to have them involved. So it avoids some of those extra steps, some of that bureaucracy. This should all be about making it as accessible and easy as possible. So I think that's probably what is important. But as I said, and there is plenty of evidence that shows that it's also not just the right thing to do, but also what gets the best results.
In terms of that evidence, as you say, there are examples overseas of where Housing First has been kind of jointly created, commissioned, and developed, with a kind of health directorate in a country as well as the housing directorate. I think you mentioned earlier, Gareth, the idea that Housing First is not just a housing issue. Homelessness is not just a housing issue, so makes sense that we need these two sectors working together. You mentioned a few examples of good practice. I don't know if there are any others that stood out to you that you wanted to raise now.
Yeah, no, definitely, and I think there was it's questions about training at times that are also worth considering, and some of the staff in Housing First projects can know a lot about about housing legislation, about some of the empathy needed as well to support people, but not necessarily about substance use, and likewise substance use workers well know very little about Housing First or housing legislation, and why should they? And I think there was a very good example in Merthyr where the substance use organisation involved there gave out a lot of training to the Housing First project on substance use issues, and also made available, I think it was prenoxide, correct me if I'm wrong with that one, kits available to Housing First staff, and train them how to use it, to say, well, sometimes if it's an emergency situation, you're going to have to use it, not us, because it is a time conscious thing. So it's important to have all those things. I think that those examples of training where taking advantage of one organization's strengths and one of the partner's strengths to feed into the others, to be able to, and again, that also creates a bit of that sense of team, that it's not just that organization there and that organization there. It's more of that joint up working again.
A great example there, because in that case, that is specific training that will end up saving lives, in the case of overdoses. So that's really interesting to hear. A couple more questions I have for you, Gareth. Why is it so important for health to be strategically built into Housing First? So we see, I've seen through the accreditation, and I know in the report you're working on, there's a lot of passionate work at a kind of local level. And again, you've mentioned some of that, and by really dedicated, passionate individuals. But is that enough? Why do we need to take that extra step for it to be a kind of strategic link?
And I'll reflect on the second part first and expand on what I was saying earlier. And it is, these individual relationships are very important, and I think it's something that I've got no evidence on it, but I think it's something that in Wales it's very much the case as well, because everyone knows everyone here in Wales. I mean, I run meetings and I bump into the mothers of some of my friends at these meetings and all that stuff. So it's something that we take a lot of advantage here in Wales, and it is a good thing in a way that these people know each other. But as I said, it's people do leave the sector, people do move jobs, and it's important that there is a strategic commitment from higher up. That means that there isn't a change when someone leaves. Yeah, maybe the personal relationship isn't the same when someone new starts and you've been working with someone for 2 years and then that person's not there, but that can be built on. What is important is that you can still rely on this person to go to this person and say, hey, I'm working with, there's someone I'm working with and they need access to such and such services. What can you do about it? What can you tell me about it? And it's important that health have a stake on it, because a lot of this is questions of leadership. It has to come from the top to the bottom. A lot of it comes from the bottom to the top, as it is. So it's important that they are engaged strategically from the very beginning and partaking these conversations strategically, because I said it for how, and I think it's a feeling that is very much felt across this virtual room for Housing First to work. Everyone has to be involved, and people will fail tenancies if they don't have the wraparound support that is required. So you have to think of it as widely as possible.
Absolutely. Thank you. One more question, and I know we could talk about this one for hours probably, but if you just name a couple of points. If I said to you, how can housing and health strengthen their relationships at both the local or tactical and the strategic levels? I know there'll be recommendations in the report, but if you could name a couple of points on how the two sectors could do that, that would be great.
Well, on the strategic side, I think that has to come first. It has to be, I think, a question about commissioning, and I think that came very clearly from some of the case studies we looked at outside of Wales. Mm-hmm. You know, there was a very good example in Manchester, but also a very good example in a London borough, which we didn't include in this, but was from previous research we've conducted. And when you had health taking a financial stake in Housing First, or even leading the Housing First project, there was more to consider of it. It wasn't just an afterthought. It was very much at the front and center of their way of working. So it's very clear from the evidence. So I think that's what the evidence has said, that the way we commission it has to be a bit more integrated. At a local level, at a team level, a lot more of a joint work in it. There's no, if you are going to be working with services, with other, if Housing First is going to be working with other services, there's no reason why there's no joint meetings every 2 weeks between these services, which in some cases do happen, and that's some of the examples of good practice, but in other cases they weren't, and it is again that us and them. It's about creating just us as a whole, and I know that's hard, but it's something I know one of the recommendations. I think that as Kim author, we're more than happy to facilitate these networks or these forums where people can work together. But it is something that should also be considered at the commissioning stage. And I think a lot of it does come down to that and the leadership shown at both levels, both by individuals on the ground, but also by commissioners.
Thank you so much. I liked that idea of rather than the us and them, we need to create this us that is invested in delivering Housing First effectively and according to the principles. Thank you so much again, Gareth. We will publish the report in due course, and we'll make sure that it's clear when that's made available. So our next session is at 2:30. I think that's the last session of the day, and we'll be hearing from a Housing First service in Vermont in the States. So please do come back for that at 2:30. And thank you so much for your time this afternoon. Thank you.